Welcome to Seeing Eye to Eye here on blackdoctor.org. I'm your host tonight, Shamika Rhymes. Let us know where you're watching from. Welcome, Asheville. I see Gastonia in the chat as well. Don't forget to share this with your network. August is Children's Eye Health and Safety Month, so we're focusing on children's vision this month. And if you have any questions at all tonight, make sure you, again, drop it in the chat, and then we'll get to those as we go along tonight. So I'm excited about tonight's guest. So first up, we've got Dr. Jeanette Pepper. She is an associate professor at Southern College of Optometry, and she provides patient care as an attending optometrist at the Eye Center in Pediatric Primary Care and Vision Therapy. Welcome, Dr. Pepper.
Hello, thank you for having me.
Thank you for joining us. And then we've got Dr. Janine Smith Marshall. She is an assistant professor of ophthalmology at the Howard University Hospital, where she has served as the director of pediatric ophthalmology and strabismus since 2007. Welcome.
Hi, good evening.
So I'm so excited to jump into this conversation. I want to remind the chat, please drop your questions in as we go along. We'll get to those throughout the evening. So let's kick off the conversation, Dr. Pepper. Let's start with level setting. How does vision develop throughout childhood, and how much vision are children born with?
Okay, there is a lot to that question. I'm going to try to keep it as succinct as possible. Vision develops by seeing. And I know that's like, wait a minute, what do you mean? Well, babies don't see very well when they're newborn, right? The way that they develop vision is by seeing things, and the nerve connections in the brain starts to fire, and they're like, okay, we want to keep doing this, we want to keep doing this. And then slowly, as the baby develops and ages, they get better and better vision throughout that infant year of life. So vision development occurs by seeing. Now, one thing I want to make certain, and I want to have distinguished here, is that sight is from the eye, meaning that are all the eye structures healthy and they all doing what they're supposed to do. But actual vision, which is the processing of everything that is seen and making sure that it's in a manner which is conducive to depth perception and things of that nature, is in the brain. So once we establish that sight is good, development or vision in the brain is what's going to further along vision as they get older. And that's going to be through life experiences, seeing, touching, growing, hearing, and having visual targets that go along with that. All of those sorts of things help vision to develop. Now, what was the second part of that question?
How much vision are children born with?
Not very much at all. When you get that newborn and sometimes their eyes are open and sometimes they're not. So eyes are all over the place and things of that nature. They may not be aligned straight. And so visual acuity is actually really reduced. It can be anywhere between 2200, 2400, 2500. And so if you think about what we know as normal vision, which is 20/20, that's way far away from that, right? And so but the more that they see things, the more that they are introduced to things, and that brain is saying, yes, I want more, that visual acuity shoots straight on up.
Oh, okay. That explains why some babies, they look like they're looking right at you, but they may not be able, they probably see like shapes and things, I'm assuming.
Exactly. Their peripheral vision is pretty good, but that central vision takes a little bit longer to develop. That's all. But you keep talking and getting visual targets in front of them and things of that nature, and that vision starts to develop right along.
Okay, thank you. Dr. Smith Marshall. So our focus tonight is amblyopia, which is also called lazy eye. So what is that, and how urgent is it to treat in children?
So like Dr. Pepper said, vision develops as we continue to grow, right? So just like baby kittens are born with their eyes closed, even though baby humans are born with their eyes open, our vision is developing. So, and when we are talking about vision, like she said, it's really those retinocortical pathways. So the connection of the image that's taken in by the eye and how that image is transferred back into the brain and processed. And so for kids, their vision is developing up until we're not really sure, somewhere between 8 and 12 years of age, right? And after that, there is a little bit still of plasticity, but for the most part, those pathways are kind of locked into place. And so anything that comes in the way of crisp, clear vision in that interim, particularly in the first 2 years of life, but certainly can happen, from 2 to 12, anything that comes in the way of crisp, clear vision can cause the brain or the occipital cortex, the area of the brain that's responsible for processing vision, to not develop properly. And one of the first signs of that is that the vision can be reduced, even if the image um, is nicely focused on the eye. So it's not a glasses issue; it's an image processing issue, right? And that can occur from a number of different things throughout childhood. The good thing about the nervous system being plastic is that not only are you going to have the kind of a situation where you can adversely affect the vision, but it also gives us a window of opportunity to be able to improve vision if we see that there's an issue, to be able to treat it and have those kind of pathways be restored into a working way.
Okay. Well, what is strabismus? I mean, I know that it's misaligned eyes, but how urgent is it to treat in children? Or is it kind of the same thing as
So
lazy?
it's not necessarily the same thing. Like you said, strabismus is misalignment of the eyes. So you can have crossing of the eyes,
Okay.
drifting, where one eye is drifting outwards, or you can have a vertical misalignment where one eye is higher than the other, right? And so strabismus can cause amblyopia, but it can also cause the inability to use the eyes together, what we call fusion.
Okay. Okay. Dr. Pepper, you look like you wanted to weigh in. I wanted to check in with you before I hop to the next question.
No.
Okay.
Dr. Smith Marshall nailed it.
Okay.
I'm just excited, and I guess overly expressive. I need to chill out, I guess.
No, it's fine. It's fine. Well, I'm coming to you anyway. So,
Okay.
what do parents need to be aware of or on the lookout for regarding early signs of these conditions and just in general vision eye health conditions?
So that's such a great question, because babies are not going to tell you that they can't see far away, right? They're going to be the ones that you're going to look at behaviors to see things. And I love that Dr. Smith Marshall talked about not being able to fuse when your eye is misaligned, because sometimes you'll see those babies or those young children are clumsy, right? Going down steps may be difficult, or running into things and things of that nature. But then also you want to see how close do they bring material to them to see, right? If a baby is really nearsighted, they're going to pull things up, right? You're not going to be able to have it out here because they can't visually see it. So up close, you're going to see that sort of thing. Another thing that I see in my clinic is parents will say, my kid blinks a whole lot, right? And it's those really strong blinks that you're like, wait a minute, what are they doing right there? And so that could be either allergies, meaning that they're trying to itch their eyes or something like that, or it can be even a high amount of astigmatism, and they're trying to really focus to see what they're trying to see. And so that squinting, that blinking, all of those things you kind of want to look for, right? And then also too, if they're with just general child development, you have to, vision and development go hand in hand. So if one is a little off, it's going to affect the development of other motor skills and things of that nature. So you want to see, okay, are they walking on time? Are they crawling on time? Like all of these sorts of things. Now, let me say this. It doesn't mean that if they're not walking on time, there's something visually wrong, but it's a possibility. So you want to be abreast and stay ahead of all of those sorts of things to make sure that the child is on the path that we want them to go, right? And then once they reach school, how are they interacting in school, right? Do they avoid reading? Do they talk about my eyes are strained when I'm in school or at the end of the day, or things of that nature? Um, all of those sorts of things you want to be on the lookout for, just to see, okay, is everything where it should be, or do we need to make some interventions here with an eye care specialist?
Mhm. Yeah, you just brought up, unlocked a memory. As a kid sometimes, and I don't know if this is normal or not, but I eventually needed glasses, but standing in front of the TV. So it's like right here, like really close.
Mm,
Yeah. And you hear people, at least back then it was stop standing so close to the TV before you mess up your eyes. Can you talk
mhm.
a little bit about that?
Okay, so when someone stands in front of the TV, it's a couple of things that can go on. One is that they just can't see it, so they get really close to it.
Mhm.
But then also, you know how when things are out of focus, like you see something and you gotta like adjust it a little bit and it gets in focus. Being closer to the television stimulates the brain to tell the eye to focus a little bit more. So it's just a sharper picture for some people, and they just love it, right? My husband is one of those. I'm constantly saying, hey, you don't have to be that close to the TV, right? But then next thing I know, if it's ESPN, he's right up there. But my husband has an astigmatism, and he just likes seeing better up close or what have you. But with kids, that's a big one. It's being really close to the TV, that there's something else going on there.
Mhm.
Right.
Okay.
So the caveat is that, you know, it's an unreliable symptom, right?
Mhm.
Right.
So a lot of times people are going to hold things close or get up close to something because they can fill their visual field with that object of regard, so they can focus their attention, not necessarily their eyes. So it can be a sign that they can't see, but usually the bigger the TV, the closer they're going to be, right? Whether
Mhm.
they have vision issues or not. So it can be a sign of an issue, but isn't always. And I always tell parents that I can't guarantee that once they get glasses and can see clearly, that behavior is going to stop,
Good
right?
point.
And then in terms of being close to the TV, just to clarify that myth, when TVs first started, the old time diode TVs, with the big thing in the back, they
Yeah.
used to give off radiation. And so that is where that don't stand too close to the TV came from.
Oh.
Okay. That, of course, was resolved maybe 1 or 2 years after TVs were
Mhm.
invented. And so, you know, you don't have to worry about that.
Thank you for clearing that up. I'm curious, y'all in the chat, let us know if you heard that too. And don't forget to drop your questions in the chat as well. So, Dr. Pepper, how is it possible that a child could have a lazy eye, but a parent just doesn't know?
So again, a child isn't going to say they don't see very well. Okay,
Hmm.
so you can have lazy eye of each eye or just one eye. And if it's of each eye, that's all the child has ever been seeing. They're not going to say, "Oh, I don't see well." That's when you're going to look for behaviors and things like that that point to the child is having a visual issue. Okay,
Hmm.
so but again, a child is not going to say, because they think everyone sees like this, right?
Yeah.
The other thing too is that if it's just one eye and not the other eye, what the brain will do is, so the brain is getting two different images. It's getting an image from an eye that sees really well, and then it's getting an image from an eye that doesn't see as well. And so the brain does not like chaos and things of that nature. So if you got those images that are totally different, it's not going to be able to fuse like Dr. Smith Marshall talked about. So what the brain will do is say, you know what? I really don't have time to make this fuse. So I'm going to shut off the eye that's not seeing as well. When I mean shut off, the nerve connections in the back of the eye aren't stimulated. So as long as that kid can see out of the good eye, they think that they're seeing well, right? So there's not going to be, again, them saying, "Mom, I can't see," or "Dad, I can't see," because they think they see just fine. That those are what the ones that you're really going to have to have an eye exam, vision screening, things of that nature, just because the visual symptoms may not be as pronounced, and there still may be a little clumsiness, right? But they adapt. Like humans are so good at adapting to what their body is giving them. So they figure out, okay, I can still adapt to something, and maybe this time I won't trip or what have you, right? So it's hard for a parent to pick up on some things when they're really well underway.
Oh, okay. Dr. Smith Marshall, I'm going to kind of combine these questions because you kind of addressed it already, but what causes the misaligned eyes and the lazy eye? But also, are some children at higher risk of getting those, especially African American children?
Okay, so lazy eye and misalignment of the eyes are related but not the same thing.
Mhm.
So amblyopia means that the vision or the visual potential of one eye is decreased. You can have amblyopia as a result of a significant focusing issue. So both eyes can be amblyopic because there's extremely high amounts of nearsightedness or astigmatism, or you can have a difference in focus between the two eyes, where one eye is much more blurry than the other, which causes the brain to suppress the image, like Dr. Pepper was talking about. You can also have misalignment of the eyes, like we talked about, crossing or drifting, or one eye higher than the other. So imagine if your eye were to have crossing or drifting of our eyes, our brain would interpret that as a seeing double. But for kids, they're naturally adapted to be able to suppress one eye to prevent them from seeing double. And so, because the brain has to consistently pick one eye to see out of and suppress the other eye, the eye that's constantly suppressed will then become amblyopic. But you can have misalignment of the eyes, and both eyes have good vision. They're just not being used at the same time, right? So that you can have an intermittent strabismus where sometimes you're using your eyes together, sometimes there's misalignment and suppression, or even a constant strabismus where one eye is drifting and the other eye is not, or sometimes it's right eye drift, sometimes the left eye drifting, and the vision's actually really good in both eyes, right? The um, but we always do get concerned about strabismus because it is a big risk factor for developing lazy eye. We can always fix drifting of the eyes, right? Sometimes we do that with patching. Sometimes we do that with glasses. And sometimes we do surgery for that. But we can't always fix lazy eye. Like I said, we have a time limited period where there is a window of opportunity to be able to intervene. And so it's really important to catch those kids as early as possible, because the earlier you catch them, the better the chance that you're able to get them to see clearly in both eyes.
Okay.
And then in terms of risk factors, fortunately, one of the good things about strabismus and amblyopia is that there isn't a higher incidence in African American communities. We do know that for African Americans, especially people in the diaspora who are living in more tropical regions, that there's a higher chance of exotropia or drifting out of the eyes as compared to crossing of the eyes. But in general, the prevalence isn't higher in African Americans than or any other global majority population than it is in Caucasians. Things that can increase the chance of amblyopia or strabismus, for sure, family history. So if there's a first degree relative, mom, dad, cousin, sister, brother who has it, then there's a much higher chance that the other people in the family will have it. If there is a history of prematurity, so typically 32 weeks gestation or younger. So if you're, even though a 33-weeker is still a little guy, really doesn't significantly increase the chance of developing eye problems. But 32 weeks and younger, there's a much higher chance of developing significant refractive errors, crossing, drifting of the eyes, or the development of amblyopia.
Okay, thank you. I'm cracking up now because of the chat. They're all saying they heard the same thing about being too close to the TV being bad for your eyes. Dr. Pepper, how are those both the conditions we just talked about? How are they diagnosed, and what happens during the eye exam to check for those?
So, in the eye exam, what we're going to do is check visual acuity, right? And once we notice that visual acuity is reduced, then our brains start to think about, okay, is this reduction due to that they have a refractive error like nearsightedness or farsightedness, or is this reduction to either something visually obstructing the eye, or is the issue because of the eye misalignment and things of that nature. So now we go in investigative mode to figure out why is the visual acuity reduced, right? So we're going to do different tests that will not only give us the visual acuity, but then also we'll do other tests that will give us the refractive error or the more nearsighted, farsighted, astigmatic, things of that nature. Now, with little kids, we can't ask them to read, the letters on the chart. So we have different visual acuity targets where we know that babies, young kids, if they can see, their eyes are going to go to that particular target. And if they can't see, their eyes won't go to the target at all. And so we have a way of determining what that visual acuity is. Now, moving on to determining their refractive error, we have ways where we shine lights that gives us the magnitude or the amount of refractive error that the patient may have. There's also screening things that we can do to see how much of refractive error that they have by shining light in their eye as well. And then the other thing is to determine if there's something visually obstructing the eye. That way, when we shine another light, we're big on lights, I guess, we can determine if the light is going all the way to the back of the eye, or if there's something that's causing obstruction. Like sometimes patients will have where one of the lids is lower than the other, right? We call that atosis. If it's past the visual axis, meaning that if it's past the part of the pupil that goes directly to the center part of the vision, that can cause a reduction in vision. Or if the patient has a congenital cataract, right? We can see that as well when we do those particular testing and stuff. And the last thing, I know I said the last thing for it, but I inadvertently missed the eye alignment test, right? There's a test we can do where we see how well, if we disrupt the patient's eye alignment, how well do the eyes come together? Do they come together back aligned, or is one eye staying out, one eye staying in, or one eye staying up? That lets us know if there's strabismus there. That's going to let us know when we do the lights to determine the refractive error, if there's possible amblyopia, if there's anything obstructing the view of us seeing to the back of the eye. That could be another form of obstructive or deprivation. That's what we call amblyopia as well. And then corresponding that to the visual acuity. One other thing we'll do is once we get all that information, we'll check that refractive error and we'll try visual acuity again. And if they start to see well with us putting on that refractive error, that prescription on them, there's not amblyopia. They just need glasses. But if they don't see well and we know that that's their prescription, then we have a amblyopia starts to pop in our heads and we go down that road.
Thank you. So that brings me to this question. When should parents be bringing the child to the eye doctor to check for these things? Or is it just when they notice that the symptoms that we mentioned earlier? Or is there a specific age where they should be coming in?
You know what? If you don't notice it, you still need to have the child's eyes examined, right? So we're a big proponent of, around 6 months of age to and older, we need to start either having some sort of eye exam, having some sort of screening just to see what's going on there, okay? We might have slightly different views on this, but the biggest thing is getting the child to a provider that can check visual acuity and see if there's a possible issue going on. we're as optometrists are more likely to do a complete examination just to see how things are going. But other professionals such as Dr. Smith Marshall, they're going to talk about, okay, when you go to the pediatrician, they're going to do a screening. When they do that screening, the pediatrician will say, hey, you need to get further tests. So it's kind of innate, built into the system that, hey, we need to have something going on here where we catch the vision of the child at an early age, because Dr. Smith Marshall told us that the earlier we catch something, the better.
Mm-hmm.
Yeah, so as a pediatric subspecialist, I'm a big proponent of the medical home. I love pediatricians. My mom was a pediatrician, and I just think, other than pediatric ophthalmologists, pediatricians are probably the best doctors ever. And the pediatrician really is a doctor that knows the kid the best, has a relationship with the parents and the patient from the time they were little, and is evaluating the patient developmentally, seeing how they're growing. The Academy of Pediatrics has come up with some specific guidelines that are recommendations to be done during each well baby check. So at every well baby check, where the patients are going in for evaluation from right after birth, and then, when they get older during the yearly checkups, there are specific things that are recommended for the pediatrician to check. Of course, they are talking to the parents about concerns. They're checking red reflexes, which is actually a very sensitive way of being able to tell whether there are any opacities in the eyes, whether there's any difference in focusing between the two eyes, and checking fixation for the child. And then usually starting around age 3, doing vision screening, which can be either photo screening, where we use a machine to check to see if the focusing is normal and equal between the two eyes, or actual visual acuity testing, where they're checking each eye separately. Fortunately, now most states are reimbursing for vision screenings, which is allowing pediatricians to do it more effectively in their office. And so we usually recommend that if a child is unable to be screened, like if there's developmental delay, or autism, or significant anxiety where the patient isn't able to be screened properly, and of course, if there's a history of prematurity, if there's a family history, for the patient to be seen for a baseline check. But in the absence of those things, with normal vision screenings, remaining in the medical home with continued screenings on a yearly basis, I think is fine. And most ophthalmologists do not recommend yearly eye exams.
Okay.
Can I add something to that? Because
Absolutely.
I got a little remiss there. One thing I do want to say is that the American Optometric Association has a program called Infant C. And with Infant C, it is a program where infants ages 6 months to 12 months are given eye exams at no charge by infancy providers throughout the country. And so if, let's say, the pediatrician says, hey, you need further evaluation or whatever, we're willing to do that at no charge for the patient. So that's great. Or just come in and see us, whether the pediatrician has said so or not. We're more than happy just to evaluate that visual system from there. Now, if there's something not found or everything looks great, then we'll say come back again at age 3, right? Because by that time, if there's something underdeveloped, we'll see it by then, and we can go from there. But if we do find something, and usually when we find something, we partner with our pediatric ophthalmology friends and things of that nature to say, hey, I caught something here, and I think we need to evaluate this a little bit further. So I love that, and even though we may have different ways of looking at the assessment of the patient, or how often that patient should be assessed, our goal as eye care providers, period, is just to make sure the child has everything they need to have wonderful vision, wonderful development from the time that they are born until the time that they are not with us anymore. So I'm just grateful to have providers that we can use to refer out when we decide that, you know what, this is a little bit further along than what we would like to see.
Thank you. Well, Dr. Smith Marshall, you mentioned some treatments a little bit ago. Can you just kind of refresh our memories as to the different treatments for the lazy eye and misaligned eyes? And then kind of go into why a patch. You mentioned sometimes the treatment is wearing a patch. Can you explain that too?
Okay, so amblyopia, like I said, means that there's a decrease in potential vision between the two eyes. And that can be caused by a number of different things, right? So it can be caused by difficulty in focusing. So one eye is more out of focus than the other, or both eyes are significantly out of focus. So the first treatment in that particular instance, it's called refractive amblyopia, is to correct the focusing issue. So we give glasses so that both eyes can come into crisp, clear focus. Now, if it's both eyes, then oftentimes glasses are sufficient and we don't need to do anything else except wear the glasses full time. If one eye is significantly out of focus in comparison to the other eye, it usually has been ongoing for quite some time. And so depending on how long it is until you've seen the patient. So if you catch the patient at 6 months, right, or 3 months, then oftentimes glasses alone is sufficient. If the kid is 7 years old and it's been something that they were born with, then sometimes we are lucky and we give glasses to correct the difference between the two eyes, and the vision improves with the glasses alone, and then nothing has to be done except to continue full-time glasses wear and wean it as needed. However, if the focusing issue is treated with glasses and then there is still decreased vision in the eye that has a significant focusing issue, then the treatment is to get the brain to start using that eye again. So like we said, because the brain hasn't been using the eye, those pathways between the eye and the brain are not working well. They're lazy, right? So we want them to start working better. And so the way to do that is to penalize the good eye. So we can physically cover the eye with a patch to force use of the eye that the brain doesn't want to use. We can use an eye drop called atropine, which causes the vision to be blurry just up close, so that when the child looks up close, they're forced to use the eye that is amblyopic, but doesn't affect the distance vision at all. Or we can use something on the glasses to blur the vision. So it doesn't completely occlude the vision, but it blurs the vision, encouraging the child to have what we call a fixation switch so that they start using the previously lazy eye. And then the more that the brain uses that eye, the better the vision becomes. Okay. We can also use patching with strabismus. So misalignment of the eyes can either be a focusing issue or a muscle issue. If it's a focusing issue, we treat it with glasses. So oftentimes glasses alone will be helpful. And then we may use atropine or patching if there is amblyopia on top of it. However, if it's just misalignment that is caused by a focusing issue, then glasses alone should be sufficient. If it's a muscle issue, then sometimes patching can help, particularly if it's drifting out of the eyes. Like I said before, when there's misalignment of the eyes, the brain in a child starts to suppress the image that is coming from the eye that is deviated or misaligned. And so if that eye is consistently being suppressed, then it's as if the brain doesn't recognize that the eye is drifting. So we use patching as an anti-suppression tool so that the brain can realize when the eye is drifting so that they're able to self-correct. And so that is a treatment for particularly drifting out of the eyes. And then, of course, if there's a muscle issue that is not amenable to patching, we can always do surgery, which will realign the muscle forces so that the deviation between the two eyes can be resolved.
Okay, thank you. I want to remind the chat, we only have a few minutes left, so if you have questions, please drop it in the chat. I want to make sure we get this, talk a little bit about children's vision a little more generally for a few minutes. Dr. Pepper, what tips can you give to parents about keeping their children's eyes healthy?
Well, there's several things you can do, right? Of course, eating vegetables, okay? And I can tell you all the things that have beta carotene and all this other stuff. I just didn't need you to eat something green, right? Just try to get something that's vegetable focused just so that the body, the eyes can develop appropriately, okay? But then also what helps, particularly when they're younger, is announcing to the baby when you're walking into the room, right? Changing the crib position or like the feeding position when you're feeding the baby or whatever, like it helps because one eye is going to be kind of covered or kind of not seeing everything, and the other eye is going to see a lot more while you're feeding and stuff. So again, to see, you have to be able to see, right? So you want every opportunity to give to that baby to be able to see and stuff like that. Reading to them is a big one, right? If they can see the pictures, they can see the pictures in their head, stimulating those connections and stuff. That is huge because that's that visual memory, that's the auditory stuff. All of it's like intertwined so that it is forming those neuronal connections that they have, right? Building blocks, right? Those are huge, right? Because that hand-eye coordination, manipulating of the toys and things of that nature helps them playing on the floor, letting them play on the floor, creeping and crawling. Those are big, right? I'm a proponent of not rushing the child into walking, right? Because that creeping and crawling gives them that time to have that vision develop, near far vision develop, and all those sorts of things. And it's just really critical that the child has time for those things to develop and stuff. Other things you can look for as the child gets older is how close are they holding their material, particularly not just reading material, but phone, tablet, how long they're on the phone and how long they're on the tablet, all of those sorts of things, right? Making sure that we monitor the length of time that they're on there, because the longer that they're on those targets without breaks, it can affect their refractive error, particularly nearsightedness as they get older and things of that nature. So those are some of the big chunks that I want parents to think about when they're trying to make sure that their child's eyes are developing appropriately.
I do see a question from Robbie Webb, and the question popped up right when you were talking about it, but they want to know, how effective will an increase in beta carotene consumption help resolve the issues of what we talked about earlier?
So beta carotene is really good for eye health, particularly in the retina, right? And so as long as that eye and stuff is particularly healthy and you're giving the eyes the nutrients and stuff that it needs, it's going to develop the way it should develop. I don't want you to go around just eating carrots all day. That's not the look, right? What I really want you to do is just to make sure that the child has a balanced number of vegetables so that they have a well-rounded diet, so that everything develops appropriately. Because just eating carrots and things of that nature, or taking those particular supplements for children, may not be as imperative as long as they get it through their vegetables and stuff like that. Now, if you're going to the doctor and they said these particular things, that's something totally different. But in a general setting, I'm not one for sitting down eating a whole bunch of carrots to make your eyes better.
And I appreciate that. Dr. Smith Marshall, We want to make eye care a priority for families. Can you talk a little bit about any disparities in access to eye care for African American families and children, that have vision conditions?
Yeah, so fortunately, I think that um, we tend to have many fewer disparities in the pediatric population than we do in the adult population, just because when we lobby and you hear children, there tends to be much more of kind of a rally around that. Okay. Um, I feel like oftentimes you'll have children who are at least seeing their pediatrician on a regular basis to do well baby checks and to do and to get their shots and all the things, and their pediatricians serve as great advocates for them to be able to get that subspecialty care that they need, right? Unfortunately, there is a huge shortage of pediatric ophthalmologists. Ophthalmologists in general, as the population is growing, and so waits to see a pediatric subspecialist, ophthalmology, endocrine, dermatology, tend to be relatively long, which is one of the reasons why we advocate for screening as opposed to routine eye exams, to be able to kind of allocate resources in the best way, so that the pediatricians who know their patients the best can kind of sort out the kids who are having real issues or kids who may not necessarily have significant issues, but whose parents are worried otherwise. And so I think that making sure that the resources are allocated wisely to the patients who are really in need and who have significant risk factors is the best thing to ensure that there's adequate care for all children who have problems.
Thank you. And
I'm gonna add
oh,
something
go ahead.
there.
Sure.
So I'm in Memphis. That's where where I practice. And what we're finding is that we're able to get our kids the screening. We're able to get our kids, sometimes we do mobile clinics, so we go to where the children are. But what we're finding is that when they're in school and the glasses break, then it's harder for them to get back to um, us as a provider or whomever else they got the glasses and stuff from. So the disparity, more what I'm seeing is that transportation issues, workforce issues, parents not being able to get off work, um, or just surviving, right? We have some parents who are just trying to make sure that they keep this afloat. And so the child's vision is not on the highest order of things to do. So sometimes the parents know that there's an issue and sometimes they don't. So what we're finding with the disparity is with African Americans, particularly in Memphis, Tennessee, is that them getting to our facility or getting back to our facility when something's wrong. It's common for us to see patients who have been out of their glasses for 6, 8, 12 months because they couldn't get back here, right? Or they got lost to follow-up, meaning that they moved or what have you. So the more so the social determinants of health, those are where I'm seeing a lot of the disparity with our African American children or Black children that we have.
Thank you for sharing that. As we wrap up, I wanted to get this from both of you. What's one thing you want parents to remember from this conversation, or take with them? What little nugget, or unless there's something we didn't bring up that you want to make sure that they know? I want to start with you, Dr. Smith Marshall.
So in general, I think that parents should, kind of trust their gut, right? Often I tell my residents all the time, listen to the moms. The moms know if there's something going on, right? And also really make sure that if you are having any issues at all, that you discuss with the pediatrician. They're the They're the doctor that knows your child the best, right? And they're more than adequately trained to determine whether it's something that is worrisome, whether it needs to see a subspecialist, or whether it's something they can take care of.
Thank you. Dr. Pepper.
What I would like parents to know is that you have to be able to see to see. And so you will have your child at a disadvantage if you don't know if they can see or not. And you can't always rely on, well, they're not bringing the material closer, they're not running into anything, so they're just fine. No, it puts them at a disadvantage at school. It puts them at a disadvantage for their development. And the last thing we want to do for our Black and brown children is to have them at a more of a disadvantage than what we already see in the world going on today, right? So make every effort to make sure your child is able to see, and if they aren't able to see, then we can start taking the steps in place to make them to see. But it's hard when they're 8 years old, because you know that third grade year is a tough year, to be honest with you. And we find out that they can't see, that they're behind on their reading skills, they're behind on their tracking skills, they're behind on their mathematical skills, all sorts of things because they could not see, they didn't process the information appropriately because of their visual dysfunction and things that they have. So in the very beginning, when them babies are born, they have to see to be able to see.
Thank you. This has been such a great conversation. I want to remind everybody that if you can head over to blackdoctor.org, there's plenty of articles about everything we talked about here. Eye health for children, lazy eye, misaligned eyes, all of it. There's articles over at blackdoctor.org. I want to thank you, Dr. Pepper and Dr. Smith Marshall, for joining us here on Seeing Eye to Eye. This is, again, great conversation. And thank you to all those in the chat. I hope you all have a great night. Uh-oh. Hold on just a second. Well, I think we could just exit, I think.
Oh, okay.
We can, yeah, because mine's still showing live, so we could just exit.
Okay. All right.
It was nice to meet y'all.
Nice to meet y'all. Bye now.
Thank you.
Bye.
Thanks. All right. Oh.